And what I want to say is that we are just going to briefly go through an outline that would cover a span of about 30 to 40 minutes of your time. We are going to delve into what obstructed labor is, the causes, how to identify and manage it. By way of management, we are keeping it pretty simple. We will not zoom into the very details of management. We're just going to deal with how to identify it, how to pick it up at the periphery, what to do when you pick it up. But when they get to the theater, we'll just tell you the options available. They will not go into fine details about how we conduct deliveries or perform procedures for obstructed labor. But if time permits in the Q&A, if you ask, we'll be able to provide you the needed answers. So I invite Dr. Okyere to lead us through this presentation. Thank you very much, everyone.
Thank you very much, Dr. Caesar. Thank you so much, boss. So we are going to look at obstructed labor, and by way of references, these are references, and this is the outline for the presentation. So definition. So obstructed labor is a condition where, in spite of good uterine contractions, the progressive descent of the presenting part is arrested due to a mechanical obstruction. In other words, in spite of good uterine contraction, there is no progress of labor due to a mismatch between the presenting part and then the pelvis. Obstruction usually occurs at the pelvic brim, but it may occur midway in the pelvic cavity or at the pelvic outlet. When labor is prolonged because of failure to progress, there's a high risk that the descent of the fetus will become obstructed. In this way, obstructed labor can be viewed or considered as a form of neglected labor. So why are we looking at obstructed labor? It is one of the leading causes of maternal mortalities worldwide. It causes significant morbidity to the mother and the newborn, even when they survive the ordeal. And in other parts of the world where things are far more advanced, obstructed labor is almost non-existent because of good antenatal care and supervised deliveries, meaning that it can be done. We can prevent obstructed labor, and the prevention is well within our capacity to implement, given the progress we have made so far in building capacity. Globally, at least 585,000 women die each year from complications of pregnancy and childbirth. More than 70% of these deaths are due to 5 major complications, which are hemorrhage, infections, hypertensive disorders of pregnancy, and obstructed labor. Obstructed labor is one of the commonest causes of maternal morbidity and mortality in Southeast Asia and Sub-Saharan Africa, including Ghana. 1 to 2% of all referrals in developing countries, including Ghana, constitute obstructed labor. Now, a community-based retrospective study that was done in Ghana some time ago found out that out of the 324 maternal deaths, 26% of them was attributed to obstructed labor. Another study that was done in Guinea-Bissau using verbal autopsies found 19% of the 350 maternal deaths was due to obstructed labor. Again, in Uganda, a study in 2006 found that 22% of all maternal deaths was due to obstructed labor. Globally, it accounts for 8% of all maternal deaths annually. The WHO's goal was to reduce mortalities surrounding obstructed labor by 75% by the year 2015, but we've not achieved that goal yet. The disease burden. Majority of obstructed labor and its related complications occur in the poor, illiterate, hard-to-reach women who are living in rural areas with limited or no access to skilled birth attendants. It is an indicator of inadequacy and poor quality obstetric care. So what are the key factors? What are the risk factors of this condition? So the key factors and the contributing to obstructed labor include poverty and the prohibiting high cost of maternal care in hospitals, ignorance and illiteracy, transportation difficulties, sociocultural belief that by all means she has to deliver through the vaginal route, late referrals, inappropriate use of pathograph, aversion to cesarean section and hospital delivery, especially after they've been through the procedure before and the ordeal that comes with it. Childhood malnutrition eventually leads to contracted pelvis and then makes the pelvis inadequate for passage of fetus. Pelvic abnormalities following childhood illnesses like poliomyelitis and pelvic injuries. History of previous stillbirth and prolonged labor is another risk factor. Young maternal age, where the pelvis is not adequately developed to carry the labor process through. Female genital mutilation, where there will be eventual constriction of the perineum because of cicatrization. Some conditions like diabetes mellitus and even gestational diabetes results in fetal macrosomia and then increases the risk of having an obstructed labor. So by way of etiology or causes, there are two fundamental ways to look at it. The first one is a fault in the passageway, which is the maternal factors, or a fault in the passenger, which is the fetus. So we are looking at the fault in the passage, the maternal factors, could be from the bony pelvis or the surrounding soft tissues, or within the soft tissues within the pelvis. So bony pelvis, we have contracted pelvis, which is very common and is typically due to childhood malnutrition. Underdeveloped pelvis, like you mentioned earlier, typically in adolescent pregnancy. An abnormal pelvis, android pelvis, arthropoid pelvis, and what have you. The soft tissue injuries, the soft tissue problems causing faults in the maternal passage include cervical dystocia, failure of the cervix to dilate adequately due to prolapse or previous operative scarring, cervical or broad ligament fibroid, or other tumors of the surrounding organs or tissues in the pelvis, including ovarian tumors, tumors of the rectum, bladder, and osteoma of the pelvic bone. Vaginal spectrum and stenosis from previous FGM scarring or rigid perineum. Now, faults in the passage of the fetus, the transverse lie, brow presentation on occipital posterior position, compound presentation, congenital malformations of the fetus, like hydrocephalus. The head is too big to pass to the canal, or fetal ascites. The head is fine by way of dimension. The shoulders are fine, but there's a fluid in the abdominal cavity, so it makes it wide enough, too wide for it to pass through the canal. Conjoined twins for obvious reasons. Big baby, and then locked twins in typically monochorionic monoamniotic twin gestation. So the pathophysiology, usually, no, typically, there's a mechanical obstruction at the presenting part. So the uterus undergoes adaptive changes by way of an attempt to overcome the obstruction that is going on. So this is evidenced by contraction and retraction of the upper segments of the uterus, and then thinning out, stretching and relaxation of the lower segments. As this goes on for some time, there's a circular groove that forms at the junction between the active upper part and then the distended lower segments of the uterus. So if you look at the picture on your right, the normal one is as visualized at A, and B is the abnormal part. If you look at the differences, the upper part has a very thick wall layer compared to the one in A. And then the lower portion, the lower segment is wider here and is distended. And then there's a circular groove that is forming between the upper part and then the lower portion. So this is known as a pathological retraction ring, aka Bandel's ring. So this is how it appears on the outside. So this is the normal abdomen on figure A, and figure B shows the Bandel ring, the upper part showing the retracted upper uterine segments, and then the distended lower segment is also seen. And in between, there's a groove that forms over there, which is the Bandel ring. And it's essential to note that Bandel ring is a late sign. In primigravida, as the uterus is trying to overcome the obstruction, further retraction stops. After sustained tetanic contraction of the uterus, at a point, it stops in response to the obstruction, and the labor process comes to a standstill. This is known as uterine exhaustion. But in multiple gravidae, the retraction continues with progressive circumferential dilatation and thinning of the lower segment. So it keeps on pushing. It's as if the uterus is like, I've been through this process before. I've pushed several babies through this. I've been through this before. So it's forcefully undergoing the contraction in an attempt to overcome the obstruction. And as this goes on for some time, the baby is pushed from the upper segment and falls into the lower segment, occupying the lower segment. So the lower segment starts becoming bigger and bigger, and then the Bandel's ring is seen to be moving nearer and nearer towards the umbilicus until eventually there's a rupture. So what morbid anatomical changes are seen in the urinary bladder? So the bladder becomes displaced upwards, which typically becomes an abdominal organ. The bladder walls get traumatized, leading to blood-stained urine, hematuria. The bladder base and urethra are nipped between the presenting part and the bony pelvis, typically the symphysis pubis. This leads to pressure ischemic necrosis. The vitalized tissue becomes infected and later on may slough off and then develop a communication between the genital tract and then the urinary bladder, forming a genitourinary fistula. So what are the effects this has on the mother? We divided it into immediate effects on the mother and then the remote. The immediate effects on the mother, we will have maternal exhaustion, dehydration, sedotic breathing because of the exhaustion. The mother moves away from using first-line glucose metabolism to fatty acid metabolism, end up to release acetone, which will be perceived through the breathing. Excruciating pain and anxiety, ruptured uterus, sepsis, increased risk for operative delivery, injury to the genital tract due to instrumental delivery, postpartum hemorrhage and shock. All these will contribute to maternal mortality. And if the mother should survive this, she may end up having long-term complications by way of fistula formation, anemia, foot drop caused by nerve injury, vaginal atresia, secondary amenorrhea following hysterectomy when the woman is taken to theater and primary repair of the uterus secondary to uterine rupture is not feasible, so hysterectomy is done, so she has no uterus to bleed anymore, or she has syndrome, severe postpartum hemorrhage causing infarction of the anterior pituitary gland, so there will be no regulatory hormones, FSH and LH, to initiate the menstrual cycle. So what effect does it have on the fetus? We have fetal asphyxia, acidosis due to persistent fetal hypoxia and maternal acidosis, intracranial hemorrhage, neonatal sepsis, neurological injuries, that's brachial plexus injury, Bell's palsy and Erb's palsy and Clamp-Case palsy. All these lead to increased perinatal deaths, stillbirths, and then early neonatal deaths. So by way of diagnosis, it's important to note that the patient would have been in labor for a long time. So she has been laboring for more than 12 hours without any progress to delivery. So it is essential that it's picked up early, and the pathograph plays an essential role to recognizing impending obstruction early. And then we have to be on alert if labor is slow to progress, and careful general abdominal and vaginal examination is necessary. Typically, the woman gives a history of prolonged labor, like we've mentioned, and the pain keeps getting severe and becomes more frequent, and there's the urge to bear down. So general examination findings. There are features of maternal exhaustion, maternal distress, which includes exhaustion and acetone breath, like we explained earlier. There's dehydration, dry mouth and oral mucosa, and then tachycardia, pulse beats of in excess of 100 beats per minute, raised temperature, scanty urine or blood urine. Then on the abdominal exam, the Bandl's ring is seen, the retraction ring, like we explained earlier, is seen on the abdomen, which is a very late sign. And then the urinary bladder is distended. And it's when you auscultate for the fetal heart, it's possible that you may not hear the fetal heart at all. Maybe there, or the baby will be in distress. Vaginal examination. The vulva appears swollen and edematous. The vagina is hot and dry, plus occasionally offensive and purulent discharge or meconium stain liquor if the membranes are ruptured. The cervix is not fully dilated or it hangs like a curtain. The presenting part is extremely molded or jammed into the pelvis, and usually there's severe caput formation. The rate of cervical dilatation is slow or remains static in spite of good contractions, cervical dystocia. So this is our pathograph that we would use to monitor the labor, and it gives us a fair idea of how our labor is progressing. On the contraction part, it to be very evident that the contractions are very adequate to push the labor process through. But when you look at the cervical graph, there's repeated CMs and there's no further progress of cervical dilatation. So what are the principles of management? The underlying principles of actual treatment are first, relieving the obstruction as soon as possible by safe delivery procedure, and then measures to combat dehydration and ketosis in no particular order though, and then we control sepsis. So the general approach of management include resuscitation, analgesia, and definitive management. So by way of resuscitation, you go through your usual ABCs, your airway, breathing, and circulation. Secure 2 wide bore access venous access. Then we take samples for full blood count, grouping and cross-matching against units of blood, renal function test, blood culture and sensitivity, arterial blood gases, high vaginal swab for routine examination and culture. IV fluids to correct dehydration, broad spectrum antibiotics, careful uterine catheterization using a Foley's catheter, and prevents further uterine contractions with tocolytic, especially in the multigravity. Anti-tetanus serum, vital signs, and general assessment of the mother and the fetal heart is done. So after the patient has been adequately resuscitated, a balanced decision is made on the best mode of delivery. And the options available are two. We have the operative vaginal delivery and then abdominal delivery, cesarean section. So abdominal delivery, the indications are uterine rupture, a live fetus, or even if the fetus were dead, the surgeon or attending physician or surgeon is unskilled in operative vaginal techniques. So in which case, we have to go do cesarean section. And notice that the cesarean delivery may be very difficult, and it would be good to inform a senior obstetrician to be on standby before proceeding. So post-operative management, you do our broad spectrum antibiotics, adequate analgesia, adequate hydration, and it's essential to retain the ureter catheter in situ for continuous drainage for about 10 to 14 days to allow small vesicovaginal fistula to heal. Early ambulation, anticoagulation, close monitoring of vitals, and good dietary support is needed. Avoid constipation and have a balanced diet that is rich in protein to promote good wound healing. Lactulose and other stool softness may be given to ensure that she has soft stools and avoid constipation. Initiate breastfeeding early to help with bonding. Psychologist assessment is needed to help the woman deal with the post-traumatic events that she may be going through. Now, the other way of delivery, the operative vaginal delivery, you can use forceps delivery, vacuum delivery, or perform in other places, they still perform symphysiotomy. And there are distractive operations that can be done. Craniotomy, decapitation, embryotomy, cleidotomy, breaking of the clavicles to reduce the size of the presenting part so it can pass, and then decompression surgeries. So this is the ventral vacuum delivery apparatus. So for post-operative vaginal delivery, it's prudent to keep the catheter in situ for at least 2 to 3 days, continue IV antibiotics, and you actively look out for fever, sepsis, etc., HB estimation to correct anemia, breastfeeding, and then you actively look out for urinary bladder and bowel injury caused by pressure necrosis. A variety of fistula may form, urinary and fecal incontinence, and future developments of genital prolapse. So this is a graphical presentation of whatever most of the things we've talked about. And from the early onset of the child's life, and the girl child's life, how malnutrition affects the size of the pelvis, contributory factors like illiteracy, lack of formal education, harmful traditional practices, all these contributing to mismatch between the presenting pattern and the pelvis, which would result in cephalopelvic disproportion. And because there are limited emergency obstetric services available, it would lead to labor becomes neglected and typically leads to obstructed labor. And then the complications associated with them. All right. So how do we go about preventing this? It starts way from the beginning when the child is young. So female empowerment is very, very important here. It's prudent to ensure that education for all, with emphasis on the girl child education, reduce early marriages and teenage pregnancy, and good nutrition in the early years of development. We need trade initiatives for women to keep them engaged so that they won't become dependent on men, which eventually lead to sexual access and lead them to have early pregnancy and then come in with a risk of obstructed labor. Legislation and enforcement to ban the practice of FGM. That's primary prevention. So secondary prevention is by community education, and the antenatal level, early detection of risk factors that are likely to produce prolonged labor. It's previous obstructed labor, suspected BBB or growth anomalies, coexisting uterine fibroids, small women, and then more presentation and position. It's also essential that we train health workers and midwives to ensure proper use of pathograph and equip health facilities with the needed resources to enable them to deliver the best standard of care, and early referral to higher centers where there's a senior obstetrician, gynecologist for quick intervention should obstructed labor be diagnosed. tertiary prevention. That's more after the woman has gone through the process, in dealing with the complications that she's having. So multidisciplinary approach is needed to help women who have survived the ordeal of obstructed labor. So you need urogynecologists, clinical psychologists, a whole medical team to help. Rehabilitation facilities that can help women who have developed fistula to improve their quality of life. And then financial support to help them get it repaired. Thank you. Hello, boss. Hello.
Okay, so hi everybody. I'm Dr. Hadfield. I'm the founder of Ghana Medical Health. Now we'll slip into questions. There weren't a lot of questions in the chat. There's one I see right now. Is it possible for a woman who has delivered vaginal multiple births to have an obstructive labor secondary to cephalic pelvic disproportion, even if the estimated fetal weight is below 4 kilograms? Would you like to address that, Dr. Caesar?
Hi, Dr. Caesar, please, can you hear us?
Right now, if you're speaking, Dr. Caesar, you're muted. Hmm.
I think you're having some network challenges.
We have some others from our project team here who are able to answer as well. If Dr. Caesar is unable to do so. Dr. Hawa,
Dr.
I think I
Okyere,
see you
please,
there.
can you have a follow-up here?
Hello, please come again.
Please, there's a question on the floor. I don't know if you can attempt to answer it. We are struggling to get Dr. Caesar answer.
Okay, so yes, so a woman who has delivered vaginally before, even though grand multiple, who estimated fetal weight is within normal range, there's no fetal macrosomia, can still go ahead and have obstructed labor. Because if you look at the presentation, we said the etiology, the causes, is by way of passageway problem or fetal problem. So she may develop other things that would lead to narrowing of the passageway, like fibroid tissues or previous cervical procedures that may cause narrowing of the cervix or prevailing tumors of the bladder or rectum or any other surrounding tissue that may impinge on the roominess of the passageway that would eventually lead to obstructed labor. So yes, multigravida who has a fetus of a favorable size may end up with obstructed labor if the passageway is not roomy enough due to these factors that I've mentioned. And I was hoping that Dr. Caesar will throw more light on it for us.
Thank you very much for that explanation. We have a similar question also that was sent. Thank you for the presentation. This is from Abdul Qadir. Where does one draw the line between CPD and obstructed labor? I'm not sure I follow the question.
Let them wait.
Oh, Dr. Caesar,
Any
hello.
more questions?
Were you able to hear that question? Where does the line get drawn between CPD and obstructive labor?
Okay. So when you say CPD, cephalopelvic disproportion, if not recognized and intervention occur, you eventually would get an obstructed labor. We usually use the term obstructed labor in rural settings, within teaching hospitals, regional hospitals, where we expect that all labors are monitored on a pathograph. We expect that you should be able to pick up a cephalopelvic disproportion from your pathograph and intervene appropriately. So in a teaching hospital, we rarely, or we don't expect, let me use the word, we don't expect a labor to get to the extent of obstructing. But you can pick it as a CPD and you should try to investigate the cause of the CPD and then intervene appropriately, either by way of management or cesarean section, whichever way you want to go. But CPD usually is the diagnosis that comes first. If you ignore your CPD findings, then we say someone has developed an obstructed labor.
Thank you, Dr. Caesar. What would you describe to maybe more community midwives or rural physicians without partographs? Because we know there's lots of partograph paper shortages, even if the hospitals have them. So what would you say for clinical examination findings when you define the obstructive labor?
So most of our government hospitals ideally should have pathographs, but where you don't have a pathograph, what you should know is that when you have a woman who is in the active phase of labor at 4 cm, if it's a nullip, you expect the woman to dilate at about 1 cm every hour and about 1.2 to 1.5 for a multi. If the patient comes in and per the risk factors doctor mentioned, the woman looks has a short stature, has a very enlarged abdomen greater than the the estimated gestational age among others, or she has a scan that shows baby is big. These are cases that when they are lagging by way of dilatation, and you realize that the cervix is getting edematous with the molding, the person is getting dry, the moisture is no more there, as in getting exhausted, dehydrated. These are signs that you need to start resuscitation and refer to the nearest hospital for intervention. Sometimes some of the antenatal books, the older ones, used to have pathographs in there. So sometimes just look through the antenatal book, see whether there's a pathograph in there or not. And now we all have technology. There are pathographs on the internet. You can use it as a visual inspection just to have a fair idea whether the person has crossed the action, the alert line and the action line respectively or not.
Thank you, Dr. Caesar. That's excellent. That answers the question Dong Regina had asked. If you were at the peripheral, what would you do as a midwife for a laboring mother before referral? So I think, Don Regina, the answer there is using your clinical skills to identify when labor is obstructive or signs of it early. So the cervix isn't changing a centimeter every 1 hour or 2 hours, and the mother's tired, or the cervix is getting increasingly edematous. So it's more recognizing early when the problem is starting and then initiating the referral early so that you don't have those complications that come subsequently. Thank you for the questions. Any other questions or any other comments? Can send me a message. I really want to thank Dr. Caesar for this excellent presentation. I enjoyed it immensely. If there's nothing else, this presentation has been recorded. We're going to be posting it to the Ghana Medical Help YouTube channel. You can see the link to the YouTube channel in the chat. I do recommend everyone follows that link and likes the YouTube channel so that the videos come up automatically on your feed. You can use the recordings to study from, to learn from, share with your colleagues, help with examinations. We'll also be posting some of the presentation files in the description below the videos. As always, I want to thank again Dr. Caesar for this excellent presentation and the whole team. This is a weekly series that will keep going throughout the year, and we'll continue adding in some in-person trainings as well. If that's all the questions, we'll let you go with the rest of your day. Thank you so much. Madasipa.
All right.
Thank you all for your time.
All right.
And
Enjoy
thank you,
your
Dr.
weekend.
Okyere, for the excellent presentation.
Thank you so much, boss.
Okay.
All right. Bye.
Bye.
Bye.